All right, welcome to our fifth Project Search HealthMatters webinar, Medication Overload, Optimal Rx When Less is More. This webinar is recorded and will be archived. You will receive an email once we have archived the webinar. So Judy, I got your question. Yes, the PowerPoints will be available a few days after the webinars, and then the actual recording will be available. I'm very excited to sort of introduce the two speakers and talk a little bit about Medication Overload Optimal Rx projects, because it was one of the projects that Beth Marks and myself through HealthMatters program were involved. So a little bit about the project. Using recommendations from general population, NorthPointe Resources, which is a community-based organization that provides services for individuals with intellectual disabilities, they examined the issue of polypharmacy in their residential program of community individual living arrangement. They conducted a comprehensive clinical review and a corresponding care plan for 20 CILA residents at highest risk of polypharmacy, and we'll explain what polypharmacy means in a second. They will be presenting the results and outcomes of their Rx project. I wanted to introduce two presenters, Kristen Hudrick, who has worked with adults with disabilities for 15 years at NorthPointe Resources, which is part of the Aspire family. She has a Bachelor of Arts degree and with a major in psychology, and has been a qualified intellectual disabilities professional for 15 years. Currently, as the Vice President of Program Services, she supervises nursing services for adults with intellectual disabilities who live in group homes. We also, I'm hoping that we're going to get Dina to join us, because I can't find her at the moment. We've been having some glitches on her end. Dina Donahue-Chase is currently the Chief Mission Officer with Aspire. Previously, Dina was the CEO, President of NorthPointe Resources, where she led the strategic vision of NorthPointe Resources, advancing the organization's mission through continued investment in program expansion, innovation, and service excellence. All right, Kristen, I'm going to unmute you, and we can get started.
Okay, great.
Go for it.
Christina, can you hear me?
I can hear you. Thank you.
Great. Thank you. So welcome, everybody. Thanks for joining us today. As Yasmina explained, NorthPointe Resources has joined together with Aspire, and we provide services for adults with disabilities throughout Lake County and the northern suburbs of Chicago area. We support individuals with intellectual and developmental disabilities and with mental illness in a variety of different services. So today we're going to be talking about this project, Medication Overload and Optimal Prescribing When Less is More. We're going to be sharing the emerging identification of polypharmacy as an issue for people with IDD, intellectual and developmental disability, the Optimal Rx project implementation in a community-based organization, and the Optimal Rx project findings. The project, which we'll describe in greater detail further along in the presentation, was a 12-month project targeted to optimize prescribing for 20 individuals living in a community-based setting. The internal team of our project consisted of a variety of different support team members, including case managers, healthcare specialists, and mental health specialists. The actual core team for the overall project includes myself, as well as NorthPointe's RN, Donna Debenham, the lead pharmacist from our external pharmacy provider, Nanette Warble, Project Director, Dr. Beth Marks, and Project Evaluation, Dr. Yasmina Cicerak. So I want to thank everybody for working on this together. Throughout the project, we worked closely with primary care physicians and specialists, and we created a cabinet of consultants, including psychiatrists, psychologists, pharmacists, and they were there to advise us when we encountered challenges, if we needed additional input, and to help us guide the project directions throughout. I would also like to recognize our funding partner, that the Healthcare Foundation of Northern Lake County, they were incredibly open to this project and championed our efforts to address overprescribing. Okay, let me just catch up here, sorry. Okay, so what is the issue? As we look at the issue of medication overload, it's important to understand what people with IDD are facing. Adults with intellectual disabilities experience poorer health outcomes than the general population. They are more likely to live with complex health conditions, have limited access to quality health care and health promotion programs. They're more likely to miss cancer screenings and have poor managed chronic conditions such as epilepsy. They're more likely to be obese, have undetected poor vision, and they also have limited self-advocacy. Some may have mental health problems and use psychotropic medications, and unfortunately, they may be prescribed psychotropic medications to manage what is described as behaviors. We do know that many people see multiple doctors and have a long history of medication usage for varying chronic conditions, and they do take many medications. And this is what leads to polypharmacy. While there is no consensus definition for polypharmacy, the most commonly reported definition of polypharmacy and the definition we use for this project is the numerical definition of 5 or more medications daily. Knowing that people with disabilities are already at a higher risk for medical problems treated with a variety of medications prescribed to improve health, there may also be negative side effects that we should be mindful of. Also, there are occasions when there may be a better option, such as a lesser dose or a lifestyle change, or even a different medication. We want to do a thorough review of all medication to ensure the optimal medication, the optimal dose for optimal health. In preparation for this project, we reviewed CILA residents' medications and found many residents had a lot of medications, some of them up to 25. And we wondered if all of these medications were actually necessary. Rates of prescribing are increasing each year, along with Americans taking more pills than ever before, with greater potential for adverse drug reactions. Health-related complexities, availability of medications and emerging medications, pharmaceutical sales, and a culture of a pill will cure have accelerated increased prescribing patterns leading to polypharmacy or the use of multiple medications by a single person. So while in instances the use of multiple medications or polypharmacy may be clinically appropriate, it is important to understand that inappropriate polypharmacy may place people at increased risk of adverse events and poor health outcomes. For example, in the elderly, we know polypharmacy is associated with adverse outcomes, including mortality, falls, adverse drug reactions, increased length of stay in hospital, and readmission to hospital soon after discharge. The risk of adverse effects and harm increases with the increasing numbers of medications. Harm can result due to multiple factors, including drug-to-drug interactions and drug-to-disease interactions. We also have to ask ourselves, have we reached an epidemic with over 70% of the population taking medication? And the global pharmaceuticals market was worth $934.8 billion in 2017 and scheduled to reach $1,170 billion in 2021. In the U.S., pharmaceuticals is a $1.5 billion a day business. That's an amazing number. Okay, medication overload. Specific to medication overload and what we suspected prior to the beginning of Optimal Rx is that in many cases, too many forms of medication are being used by a single person. There is potential for more drugs to be prescribed than clinically warranted, or even when all prescribed medications are clinically indicated, there are too many to take, called the pill burden. This has a potential to cause higher adverse drug reactions, or ADRs, and drug-to-drug interactions. And there is an increased risk of medication errors, such as wrong time, missing doses, possibly getting extra doses. The financial impact of a polypharmacy-related problem translates into a significant cost to the health system, and it has a financial bearing on patients as well as institutions. Lack of proper indications, inappropriate dosage, and subclinical toxicities of medication are of concern. Prescribing cascade is a known problem where medication results in an adverse drug event that is mistaken as a separate diagnosis and treated with more medications, which puts the patient at risk for additional adverse drug reactions. We wonder about the benefits. Is it an easy solution? Do we miss alternatives? Can someone change eating habits, move more, stress less, rather than being on additional medication? Another barrier is that it's hard to coordinate among various doctors. Managing of medications with multiple different prescribing doctors is difficult to do. So optimal prescribing, what can we do? You might think this would be a default in the healthcare system, but unfortunately it isn't. For many reasons, the influence of the drug companies, the shortage of time during visits, doctor visits, it tends to be much easier for doctors to prescribe medication than it is for them to deprescribe. And once prescribed, medications tend to just stay and be refilled almost indefinitely. The result of all this is that older adults and people with disabilities are often on a lot of medications. But when we take a close look, many of these can and should be deprescribed. Medications that are most important to consider when deprescribing are balance and fall medications for behaviors, brain function, cognitive. Those include psychotropics, antineuroleptics, meds for Alzheimer's disease, etc. Also, over-the-counter medications, non-steroidal, anti-inflammatory drugs, MCCs, medications that lower blood sugar, diabetes, etc., and then opioids and other pain medications. Okay, polypharmacy and new normal. So as we began to think about the Optimal Rx project, we discovered that most research and information involving polypharmacy falls within the elderly population. There's very little research related to folks with IDD, and that data varies a lot, with exposure to polypharmacy ranging anywhere between 11% and 60%. According to National Core Indicator data, is that people living in group home settings tend to be prescribed more medications than those living in home settings. One additional consideration for folks with IDD living in community residential homes in Illinois is the lack of a systematic process to routinely review prescriptions for optimal prescribing levels. New medications and medications changed are screened by the pharmacist to vary prescription accuracy, or to verify prescription accuracy, and red flag any potential drug-to-drug interactions, but not specifically for the purpose of optimal prescribing. NorthPointe residents receive health care from local physicians, and a contracted pharmacy fills their prescriptions. At the start of the project, data from 60 individuals living in CILAs, or community integrated living arrangements, show that 10% take 5 to 8 medications, and that is within the polypharmacy range. 83% took more than 8 medications. So by far the majority of people took more than 8 medications. 60% were diagnosed with co-occurring mental illness and behavioral health needs and took psychotropic medications. And 50% of them were over the age of 50, with most having MCC necessitating multiple specialist care for lengthy periods of time. We note a prescribing cascade as side effects or new diagnoses lead to new treatments, and medications are the primary health care intervention. In addition, physicians are resistant to changing or reducing medications prescribed by other physicians, and our contracted pharmacist only reviews medications for correct dosages and interactions. It's our belief that people with IDD will have a better shot if they only take medications that help rather than harm. We want them to be able to live, work, learn, and play in their communities, so they need optimal prescribing for their medications. Okay, and what we started. So, as I shared, national data suggests we had a strong need to look at the issue of polypharmacy and how to reduce overprescribing among the people that we support. We started with a belief of a better shot. People with IDD have a better shot to live, work, learn, and play in their communities if they only take medications that help rather than harm, and if they take the minimum amount of medications to optimize health and well-being. This is especially important because polypharmacy is now conceptually perceived as a disease with potentially more serious complications than those of the diseases these different drugs have been prescribed for. Our clinical services project. Part of this project, we reviewed, we considered, and we documented results. The Optimal Rx project was established to operate for 12 months with 2 sets of cohorts, 10 residents in each cohort. The initial phase of the project focused on the medication clinical review process and completing the corresponding medication action plan for 20 residents who were at the highest risk for inappropriate or excessive polypharmacy. These individuals also had an express goal to reduce unwanted or unnecessary medications. This part of the project was concerned our learning phase as we assessed tools, protocols, physician response, and defined the internal protocol for our best practice to move forward. The final phase of the project was to document our results and to develop an internal protocol for sustainability. Our long-term goal was to decrease medications and improve functional and health status, as well as increasing knowledge among caregivers. To do this, we engaged the ARMOR process. ARMOR, A-R-M-O-R, stands for assess, review, minimize, optimize, and reassess. ARMOR is an effort to approach polypharmacy in a systematic and organized fashion. Functional status, its restoration, and maintenance are the primary outcome goals. The tool also emphasizes quality of life as a key factor for making decisions on changing or discontinuing medications. Use of a certain medication is weighed against its primary impact on primary biological functions. And I'll speak a little bit more about the ARMOR process. Yasmina, if you can go back to the getting ready and engaging for change. Thank you. So once our initial review was completed, it was time to engage the resident themselves and their team. So each person and their family participated in an Optimal Rx share meeting. At the meeting, we discussed medical history, experience with medications, goals for medication reduction or maintenance, and we asked the question, if you could change or remove one medication, what would it be? In many cases, individuals and their families were not really aware of their medication regime, and they didn't know what side effects they could possibly have. Some were also afraid to make changes to medications, considered on past experiences. If somebody had a bad experience with reducing or changing a medication in the past, it would make them fearful to change medications again. But several were actually all in, wanting to eliminate as many medications as possible. All were happy to participate and discuss our project and intent. We got really good support from families and individuals. We do have individuals who have state guardians. They actually opted not to participate closely. They pretty much defer to doctors' recommendations. So they were supportive of the project but didn't specifically participate. Before we started our review process, we contacted some of the doctors who provide medical care to multiple CILA residents. We explained the process, asked for the support up front, and we asked them to sign a pledge, basically agreeing to the project and giving their support up front before it even started. We did gain support from a psychiatrist and a primary care physician, both of whom provide care to a large number of our CILA residents. So we are happy to have that support. We didn't gain a response from a few physicians, but it's really hard to know if they didn't approve of the project or if they just simply didn't have the time to address the request. Regardless, all physicians that we met with throughout the project were receptive to requests to reduce or eliminate medications. So we asked physicians to read and commit to this project by signing the pledge. We pledge to act in the best interest of the people we support at all times, and will promote alternatives to medication such as active support, intensive interaction, or positive behavior support. We also trained staff. We trained them on the detail of and the issue of overprescribing, the risks and benefits of alternatives, and reductions in medications. Staff were engaged and responsive to the project. We focused on, if you see something, say something. Many were also learning about this as it relates to their personal health care and of their loved ones. So not only what they can use this for in their jobs, but in their personal lives as well. We also provided some self-advocacy and health education to individuals who participated in the project. Individuals in the project participated in a UIC-developed health education curriculum and advocacy courses, including Know Your Body, how medications affect their body, physical activity and eating habits, and how to discuss your medication and who to discuss your medication with if you have questions. These courses supported advocacy and health education efforts. Okay, now back to the ARMOR process with a little bit more detail. So together with a multidisciplinary team, and the pharmacist really started us off with this project. We applied these following steps with the ARMOR process. The A is for assess the individual for a total number of medications and for certain groups of medications that have potential for adverse outcome. We reviewed for several things. We reviewed for possible drug-to-drug interactions, drug-to-disease interactions, drug-to-body interactions, the impact on functional status, and we weighed individual medication benefits against primary body functions. Next, we focused on minimizing non-essential medications. Elimination or reduction of medications that clearly lack evidence for their usage. Elimination or reduction of medications whose risks outweigh benefits and that have high potential for negative impact on primary functions, such as appetite, weight gain, pain, mood, vision. Then we focused on optimizing by addressing duplication. We found that there were some people who had multiple medications for the same purpose and redundancy. And then lastly, reassessing and monitoring for changes, improvements in the process, and clinical status. Okay, the process of deprescribing. So the process of deprescribing works by creating an up-to-date list of all the drugs a person is currently taking. So that's something we needed to have up front, a complete list. We reviewed the reason each medication had been prescribed and considered whether the medication is likely to be risky or cause harm to the person. We also considered if there was a safer alternative for the person. Discontinue or reduce doses of medication when possible. So that was a number of different recommendations that were made. And then make a plan to follow up on the deprescribing plan. The optimal Rx Flowchart, like I said earlier, starts with the nurse and pharmacist review. So the pharmacist was the one who gave us the initial review, and we discovered that there was some cleanup that needed to be done, specifically with documentation from pharmacy records. So that was really kind of our first step in reviewing the medications. And then the pharmacist and nurse, they did their review, and that was clinically based. They looked at each medication. They looked at the directions, the dosage, the date it was written. They looked at the individual's diagnosis, their age, and their gender. Recommendations were made by reviewing all of those things, and then those recommendations were brought to the individual's team. And the individual's team consisted of the individual themselves, guardian or family members, and some staff members who support the individual, like their case manager and healthcare specialists. So the initial recommendations were reviewed by this team, and then they also went through and looked at the medications, directions, you know, why things were prescribed, how long they had been on something. And this group really looked at this based on observed behavior and lifestyle. So this is the group that knows the person really well and could relate to their lifestyle and their everyday behaviors. So recommendations included reducing or discontinuing medications. These recommendations were thoughtfully made and included suggestions for assessment, such as labs and tests. Team recommendations also included alternatives to medication, such as dietary change, exercise, mental health treatment, simple things like getting outside to replace vitamin D pills. Then the next step was to bring these recommendations to the physicians. So our individuals in our CILA homes have a healthcare specialist who is assigned to work with them and bring them to their doctor's appointments and help them advocate and communicate to their doctor. So together, the healthcare specialist and the individual brought the recommendations to the doctor for review with the understanding that the ultimate decision regarding the medications is up to the doctor. And as I said earlier, we got pretty good response from the doctor, from the physicians that we work with, and we did see some success with this project. Okay, I thought it would be helpful just to share some stories about some of the success that we saw. So meet Joe. Joe is a 48-year-old man. with a primary diagnosis of a mild developmental disability and autism. He's also diagnosed with chronic constipation, hypercholesterolemia, GERD, and anxiety. Before this project started, so specifically with him, his review was done, I think, in May. And in April of 2019, Joe was taking 7 medications every day and then was prescribed 6 additional PRNs. So he had a total of 13 medications. After a review by the pharmacist, nurse, guardian, and team was done in May, by September, Joe's medications were reduced to 3 routine medications every day and 5 PRNs. And then after further review by the physician, Joe is now taking only 2 medications each day and has 5 PRNs. And 5 PRNs, PRNs for our population are often things like acetaminophen, ibuprofen, cough syrups, things that you or I would most likely buy over the counter, and we want to make sure that they have these things on hand should they develop a headache or a cold or something. They don't have to wait for those to be ordered again. So Joe was able to stop taking a cholesterol medication and a dietary supplement after labs and a review of his diet and exercise habits. His guardian was really supportive of this project. He was very supportive of this project. So overall, it was a really good outcome. Our next individual is Mary. Mary's a 37-year-old female diagnosed with mild MR and cerebral palsy. Mary has multiple other diagnoses related to her primary disabilities, including chronic constipation, GERD, gastroparesis, general swelling of her body, chronic lumbar pain, and major depression. Mary's legally competent to make her own decisions, but she does rely on guidance from her family and her caregivers. She's a really strong self-advocate, and being as independent as possible is very important to her. So when she heard about this project, she was really gung-ho from the beginning. In February 2019, Mary took 15 different medications every day and had 9 other medications prescribed as PRNs for a total of 24 medications. In March, the pharmacist and RN reviewed Mary's medications and made initial recommendations. Mary and her team then reviewed these recommendations and made a few more recommendations of their own. Mary then went to her primary physician with the assistance of her healthcare specialist, and she was able to advocate for these changes and the recommendations that she had and her team came up with. In July of 2019, Mary was taking 9 medications every day and 10 PRNs. So there was a drop in the number of medications she was taking. A follow-up review is scheduled for April of 2002. And throughout this process, Mary shared that the review process has really made her feel empowered and in more control of her health. Okay, so our results so far. So medication review, our initial data, we did a clinical review on 59 CILA residents. There were 158 recommendations for reduction or removal of medications for the first 20 people reviewed. 40 of these medications were discontinued. 25 medications were decreased. 46 medications are still pending doctor review for approval or decline, and 47 medications remained unchanged. We are still reviewing these medications. It's a process to make these reviews and then take this information to the physicians. One of the things we realized was we want to coordinate going to the doctors with appointments that they already have, so we're not having to make additional appointments. So there are some appointments that we haven't gotten to that we have scheduled and will be seeing more information about the review in the near future. Okay, initial stakeholder SWOT analysis. So this is specifically from staff. Some of the strengths that were identified is we got buy-in right away from staff. Staff liked the idea of it when they learned about the high number of medications that people were on. They were as astounded as we were. And then families as well. When we really sat down and started talking to families about this, they really were on board. We didn't get any pushback from families. Some of the weaknesses that were identified in this project are staff workload, resistance. Well, we really didn't have a whole lot of resistance, other than there were some people who were a little leery of changing medications because of past experiences, specifically with behaviors. One of the weaknesses was lack of documentation process. And there's a lot of documentation that needs to be done with medications. Documentation comes from the pharmacy. There's systems we utilize in-house with documentation. So coordinating all of that did take some time. Some of the opportunities identified, there are some really promising results, support for complementary care. One of the things that I really liked out of this project was looking at alternatives to medications, helping people to become more active, eating healthier. It's something that we have always taught and educated people with disabilities on, but being able to tie it to a reduction of a specific medication really gave it purpose. And then identified threats. Perceived increase of staff time. This is something that we're working into our process, and so it did take extra time from a number of different positions in our agency. And then also the capacity for complementary care and lifestyle changes. We do a lot to educate individuals on the benefits of exercise and eating healthier, but it can be a challenge too. So working with individuals to learn those things does take a lot of repetition and a lot of time. Okay, so what's next? So results of the Optimal Rx project are promising for NorthPointe residents. We know that people are taking in less chemicals. They have increased self-efficacy and greater control over their medications and their health, and there are cost reductions. However, we recognize there is additional work needed to sustain optimal prescribing and reducing medication overload for people with IDD. Additionally, creating a systematic infrastructure that supports optimal prescribing requires the engagement of all key stakeholders. We also recognize that our results have broader implications for the general population of persons with IDD, and we want to continue our efforts to share this information and incorporate innovative practices that are being developed for other populations, specifically people aging in the general population. Therefore, we will focus our efforts over the upcoming year on systematic infrastructure and seek ways to advance additional efforts for broader reach, as we firmly believe polypharmacy is a significant issue impacting quality of life. So next step in internal protocols. Okay, so we wish to continue to review our pilot data for additional recommendations, as well as the possibility of an expanded intervention. We will continue to collaborate efforts with our pharmacy and each primary physician to address optimal prescribing goals, and as appropriate and feasible for individuals with IDD to consider working with healthcare providers that incorporate optimal prescribing practices. We'll continue the practice with the remaining individuals in the CILA program. We will track data. We will engage key Optimal Rx leaders, including our nurse, our Associate Director of Quality Improvement, and hold monthly meetings to identify our opportunities for improvement and resource gaps. We'll request leadership and healthcare personnel to sign the Pledge for Optimal Prescribing. We are planning to introduce medical overload, optimal prescribing when less is more into new hire and annual training for all of our employees. We'll provide medication review for each CILA resident at least twice a year at their annual and 6-month meetings. We'll include consultation with pharmacists and their primary physician. We will include the following 2 questions at each healthcare visit. The attending healthcare advocate will either ask or support the service, the individual with IDD to ask 2 questions. One is, can any medication be reduced or discontinued? And the second question is, what are the recommendations for lifestyle changes, such as food options and choices, drinking more water, moving more, that will engage conversation with the physician. We will provide continuous targeted healthcare advocacy and environmental designs that promote nutrition and exercise classes and physical spaces that promote healthy choices as the easy choice for individuals with IDD. Okay, is there one more slide or is that it?
This is the last slide.
Okay, great.
Oh, there were 2 next steps.
Oh, did I miss 2? I'm sorry.
One is internal, and then one is just general next steps.
I'm sorry, I missed 2. The quantify the cost. So we'll quantify the cost of reductions associated with deprescribing of medications, as prescription medication costs are the primary driver of total healthcare expenditures for people with IDD. And we'll also explore, in partnership with UIC and consultants, a next level protocol for targeted reduction of high prescribing medications. Okay, Yasmina, do you have anything to add?
Yes and no. Thank you so much, Kristen. Just if some of you are wondering which ones were deprescribed, when we looked at a lot of them were antihistamines, corticosteroids for allergies, laxatives, and topical antibiotics. So many of them were antibiotics for the eyes and skin. So those are the ones that were deprescribed the most. Also, when we looked at, there were some antipsychotics, anticonvulsants, and some cholesterol meds that were deprescribed. So just kind of like thinking about the classes that were deprescribed. Then we did have a question. What was the presumed negative impact of vitamin D supplements? Even with natural light exposure, many individuals run low on vitamin D in the Northern Hemisphere, according to research. I don't know if you are privy to that, since
no, I don't
I'm
have
assuming it was the nurse and the pharmacist.
That was an initial recommendation made by the pharmacist and the nurse.
Okay. Thank you so much. Please let us know if you have any questions and put them in a question and answer box or a chat box, and I can read them out loud. One thing that I was also, I don't know if you've mentioned, is how long did it take on average to review one case and looking at to review the medications for one case?
Yeah, so it took the estimated time the pharmacist and the nurse review was probably 15 to 20 minutes. You know, they're a lot more familiar with the medications and can look at it rather quickly. And then the next level review with the individual, their family, guardian, and our staff did take considerably longer, depending on the number of medications that individuals were taking. Oftentimes we went through, you know, line by line, medication by medication, really talked specifically about it, what it was, how long they had been taking it, what it was prescribed for, and then any side effects. And then engaged in conversation about recommendations, answering questions from family members and the individuals themselves. So that probably took, on average, about an hour, sometimes longer.
Thank you. We have a question from Tina. She said, thank you so much for sharing. This is so exciting. Are you able to share the pledge for optimal prescribing and or training materials used?
We can share the pledge. Yes, I have that. Is that something we email out?
Yes, that is
okay.
Something, Kristen, if it's okay with you, we can post it when we archive this webinar. We can also post it as supplemental materials. The training, I think we need to talk about that just because it is a project which was funded, so we just need to be careful how we are sharing at the moment. But just stay tuned and we will figure something out with that. Next question. What recommendations do you have if a doctor is not interested in recommendations made by a review team, such as SST?
If a doctor is not interested
in recommendations made by a review team?
Well, I mean, you know, we went into this knowing that ultimately it's the doctor's decision on if they're prescribing or not. Sometimes guardians will get more involved and directly talk to the doctor if we run into something like that. Overall, though, we didn't see a lot of that. Most of the doctors were willing to have that conversation. We did have to be just aware of time. If we went into an appointment that was just scheduled for a quick follow-up for something, there may not have been time for a larger discussion, so additional appointments sometimes were required.
Thanks. From Yvonne, did you do a case on a younger subjects or younger residents? And if so, did you see a difference because they were younger?
I don't believe we've looked at it from that perspective yet.
We looked at only 20 specifically, so I think that any assumptions would be, it's too small a sample to really draw any conclusions. And then from Valerie, were any medications replaced by CBD?
Replaced by what? I'm sorry.
Are we talking about like CBD oil? I'm not sure what CBD is. Let's see if Valerie writes back. For Mary Ellen, very interesting. Were there any occurrences of the behavioral issues that staff had worried about prior to the study?
No, there weren't. We have different behavioral supports for individuals. We engaged their therapists, BCBAs, and other clinical staff to put supports in place, additional supports in place.
So from Valerie, she's confirming, were any medications replaced by cannabidiol? I hope I'm pronouncing that correctly. So cannabis derivative.
No, actually that has not come up. We have not had anybody request that.
Another question, how do you overcome physicians who do not buy into deprescribing medications?
Like I said earlier, we really didn't get a whole lot of pushback from the physicians. It seemed to be more about finding the time to sit down and have that conversation with them. The individuals and the healthcare specialists really have a lot of training in self-advocating, and a lot of these physicians are physicians that we've been working with for a long time, and they're really aware and experienced in working with this population.
And then we have a comment from Tina. Wonderful, thank you for sharing the pledge. I'm interested in collaboration in Kentucky's waiver case management in any way I can. So Tina, we'll be in touch with you. Thank you. We got your contact info. Any other questions? Please put them in. While I'm waiting for additional questions to come through, some of you may be familiar. We did a quick survey talking about optimal prescribing on our HealthMatters listserv, those of you who are on it, and we received quite a few responses. So over 60 people responded, and there are some really interesting themes that came through it. We did not have the time and did not want to take away from this presentation today, but we want to put together additional presentation and show you some of those results and sort of kind of start thinking about even what you can do, take home messages, or what can you do in your organization, even if there's no money or there's no official project that is dealing with this topic. So stay tuned. We're going to be adding something probably in June, since we have a couple of more webinars that are already scheduled. So we will add an additional one. We have another question from Rose. Physicians sometimes do not find families credible in their requests. What can a family do to enhance their credibility when asking for medications to be deprescribed?
I think collaboration with the pharmacist and the agency nurse makes a big difference. So everybody's on the same page and understanding the purpose of the medication and the history of the medication.
And I think these are some of the questions that we're really going to try to answer in this next webinar in June as well. So we'll work together to, like, these are some really great questions. So essentially, we really want to start a national dialogue on the topic of over-medication among people with intellectual disabilities. I think it's a comment from Valerie. Thank you. It would be useful to have a few additional slides to capture great verbal presentation, especially on the challenges faced by people with intellectual disabilities with respect to health outcomes. Okay, so meaning the background information or things that we know. Yes, definitely. We really were running out of time when we were timing this presentation, so we had to something had to give. But thank you for that comment. Please we have about 4 more minutes, so feel free to put any comments or questions or even the topics that you would like to see discussed on medication management. So anything that you would find helpful in the future, we would like to hear from you. Kristen, in the meantime, while we're waiting, do you have anything else to add?
No, I'm just excited to continue to move this project forward. I think we've learned some really good things, and there's a lot more that we can learn and then share.
All right, Kristen and I are still going to stay on for the next few minutes. If anyone has a lingering question, please put it in the chat box. Otherwise, like I said before, we will prepare PowerPoints and the pledge and this recording shortly and send it to you when it's ready. Thank you so much. Thank you, Dr. Archer, for your comment. Have a great rest of the day. We're going to stick around and see if we have any other additional comments. and we will be talking soon. Make sure to join us for webinar 6 on April 14th, the Caring for Adults with Disabilities study. And I'll send that information through our listserv as well. Thank you. Tristan, we'll just stick around for a few more minutes and to see if there are any questions.
Okay, sounds good.
I don't think there are any more questions, so feel free to sign off. Thank you so much. This was really cool.
Okay, thank you.
Bye.
Have a great afternoon.